This time on the procedure. The mitral valve lies between the left atrium and the left ventricle. It is supposed to be a one-way door that keeps oxygenated blood flowing into the atrium and out to the body. However, sometimes, due to disease processes, age, or infection, the mitral valve can become weak and compromised, allowing blood to flow backwards back into the left atrium because the valve leaflets no longer close completely. This condition is known as mitral regurgitation and can lead to severe quality of life issues, even death. Shortness of breath, fluid retention, lightheadedness, rapid heartbeat, and fatigue are all symptoms of this debilitating condition. In recent years, there has been advancements in the treatment of mitral regurgitation. Technology that has allowed patients with a mitral valve leak to return to their normal lives without having to undergo invasive open surgery. Today, we will be taking you into the endovascular lab to show you a new procedure, a treatment where a catheter inserted into the groin can deliver a clip that pins the mitral valve together, minimizing the debilitating leak and returning patients to a happy, normal life. The procedure is made possible by educational grants from Abbott Laboratories and Siemens Healthineers.
Ladies and gentlemen, welcome to The Procedure. And for those of you who have been to our community event in the past, welcome back. A big and hearty welcome back. You don't know how happy I am to say that. After a one-year hiatus, the Scottsdale Interventional Forum is back. A forum where hundreds of doctors from around the world come to learn, and we at HonorHealth are pleased beyond words to welcome you again for the community event portion of the forum. The community event, our annual tradition, is our modest effort at offering hope and an opportunity to show that we care. For this, we look to the past, and I offer you Ecclesiastes 19:9. What has been will be again, what has been done will be done again. There's nothing new under the sun. It has been our 2-decade-long tradition to begin each forum with our heralded community event. This year is no different, except that to reach more people, it will be televised live on TV, a TV program we are calling The Procedure. In the coming days, we will show the world how far we have come and will go to save lives, despite a virus that has killed so many of our brothers and sisters. We will show you we want this very badly, and we will not surrender to fear. T.S. Eliot wrote, "Only those who will risk going too far can possibly find out how far one can go. And sometimes things become possible if we want them bad enough." We at HonorHealth are betting on that vision and welcome the challenge. The Scottsdale Interventional Forum and the community event in this time of pandemic is to find out how far we can go, because we want it bad enough and we want you to be a part of it.
Well, welcome to The Procedure. I am Brad Perry of the Arizona Daily Mix. Dr. Rizik and I have been spending some time together leading up to this. I am very excited. I am thrilled to go in the operating room into your office, which is going to be kind of neat. But let's introduce them to the team here.
Well, this is our team, and our team, Brad, is made up of multiple disciplines. I'm an interventional cardiologist, as we've spoken. Dr. Mullick Shaw is an interventional cardiologist. We have Dr. Robert Riley, who's our director of cardiovascular surgery, open heart surgery, and Dr. Robert Burke, who is our director of imaging, of non-invasive imaging for the. So this is a collaborative effort that we're going to put together today.
So, and you were telling me back pretty much, almost 10, 15 years ago, you wouldn't have a team together like this, would you?
No, actually, what we're going to see today in terms of a heart valve repair, historically, was the domain of the open heart surgeon, wasn't it, Bob?
Correct. So we've been doing open heart surgery on mitral valves for at least 70 years, and now we're branching out into less invasive ways of doing things, including the mitral clip.
So what has happened in the last dozen years is there's been a beautiful collaboration between the open heart surgeons and the interventional cardiologists, sort of like Reese's peanut butter cup. You put peanut butter and chocolate together and you got a whole different flavor. We've created a whole different flavor of care for patients with heart disease. And now when you add the non-invasive imager like Dr. Burke, someone who's an expert at looking at these structures on CT scan and on echocardiography, now you have the makings of a real team collaboration. So we don't work in competition anymore. We work in collaboration with each other.
I love it. All right, you got some slides here to show me what's going to be taking place today.
What we're going to do today is a non-surgical repair of the mitral valve. Surgery is a great option, but in this case, the team has chosen to do a non-surgical repair. Dr. Burke, you want to talk about the valve we're seeing here?
So what we're seeing here is this is the main pumping chamber of the heart, the ventricle down on the bottom, and there's a thin line that is composed of two pieces. There's an anterior and a posterior leaflet of the mitral valve, and then on top of the screen, that's the left atrium. That's where all the blood comes from the lungs to get back to the heart.
Can you go to the next slide? And now what are you seeing, Bob?
Now what we're seeing is that this color image shows you that blood is flowing up toward the left atrium and back toward the lungs where it should not be going. That should all be going down toward the ventricle. It should be going to the bottom of the screen.
And what do we call this disorder?
Mitral regurgitation, meaning the blood is going forward and then regurgitating going backwards.
And what are the symptoms that people feel when this occurs?
So if the blood's going backwards, you can have swelling in your feet, you can have shortness of breath because the blood actually goes back into and soaks the lungs, and you can even have what's called congestive heart failure, which can cause things like dying.
Next slide. So what we hope to do today, what we plan on doing today, is you can see this blue color going backwards is the leaky mitral valve. We're going to take a clip and actually clip that valve, those two leaflets, bind them together, and eliminate the leaking of the mitral valve. Now, Bob, cardiology did not make this up, did we?
No, this was adopted from a surgical procedure that was developed in Milan, Italy, where a surgeon, in addition to a regular routine repair operation, sewed the two leaflets of the mitral valve together and created what he called a bow tie repair. And that has been adopted into this technology.
So really, this is another good reason why the surgeons and the cardiology working together in a collaborative nature is so important. We're actually borrowing from the operating room a procedure that we can now do without opening the chest.
Wow, and this is such an amazing procedure that we're going to see. We're going to see it live right here. And I'm a little nervous, but I shouldn't be, right?
No. We've got plenty of hands on deck to help you through the procedure.
So, all right, are we going to take a look at actually how this is going to work?
Sure, go ahead and show the next slide. So this is what the clip looks like when it comes in contact with the mitral valve. Next picture. And Bob, you want to describe what you're seeing here and here?
Yeah, so on the left side, you can see that to begin with, before we put a clip in, there's that big jet of red going back toward the left atrium. That's the blood that's regurgitating or leaking through the mitral valve.
And after we put the clip in?
You can see that there's no leftover leakage. So you don't see that big bright jet of red and orange flying back into the atrium.
And that's what really allows for alleviation of symptoms with these patients, isn't it?
And that's probably the single most important thing. What happens is that the pressure inside the atrium goes down. That blood that was going back into the lungs is now leaving the lungs normally, and people can breathe better again.
I know you have a story here about a patient of yours.
This is a tremendous and a heartwarming story, and it really shows what the value of this technology is for very sick patients who have no other option. I think what you're going to see is how symptomatically improved he was and how this returned him to his life.
Wow, let's take a look.
My name is Jim. I'm 76 years old. I was considered a stock specialist. I was instrumental in developing a measurement that's still the primary measurement today. And I became a household name in the institutional business. I've had a series of medical problems throughout since 1990. massive heart attack. By 2001, I had another massive heart attack, and they gave me a quadruple bypass. They ended up giving me a defibrillator pacemaker. 2006, I found out I had bladder cancer. Then, last year, I suffered heart failure. I think a lot of my problems developed because of smoking. I was a heavy smoker. I didn't watch my diet as I should have. I still exercised. I exercised every day. It made me feel great until I couldn't do it anymore.
I started to notice a change sleeping. So he wasn't able to lay in bed flat and breathe. There was a lot of jumping up at night, catching his breath.
I think the fact that he continued to work out with the trainer for many years did help him. It sort of delayed the onset of symptoms, but when he began to deteriorate, he deteriorated very quickly.
I went to the doctor's office and they gave me the echocardiogram. And the next morning I got a call from Dr.Rizik telling me that I have a significant leak in my mitral valve. And he would like to get this done as soon as possible.
And then it became really bad.
He sort of had the wheels fall off near the end of 2020, and that was really sort of precipitous and not expected. His wife was really concerned about it right before Christmas, that things weren't going all that well and that he clearly just was not himself anymore.
We sat up all night in the living room. He was literally gasping for air. I knew he wasn't going to make it if he didn't have this procedure done immediately. He was scheduled for the procedure 2.5 weeks out, and I called Dr. Rizik and I said, he's not going to make it. He needs to come in now.
Dr. Burke and I decided that what we needed to do was to perform a mitral clip procedure. A mitral clip is a procedure in which we use a device, a clip, to bind those leaflets together, those mitral leaflets, and reduce the leaking of the mitral valve.
I knew in my heart, because of Dr. Rizik's skill set, that he was going to come through it. I just knew. He has a great team, and because of this A team, it worked.
We're able to get that valve repaired with a clip and improved that leakage, basically got rid of all that blood flow going back into his lungs with every heartbeat. As a result, he felt markedly better as soon as we got the clip placed in him. He ended up being able to get home, but then unfortunately contracted COVID and ended up hospitalized yet again for management of the pneumonia that goes along with his COVID.
COVID was horrible. I had trouble breathing. I had trouble sleep. I couldn't lay flat. I had trouble sleeping. I was coughing like a maniac.
I believe that had we not performed the mitral clip procedure on him, he may have succumbed to COVID-19 and pneumonia, which he had. We were fortunate. Timing worked out very well, and along with the expert management of our critical care physicians and infectious disease specialists, he actually did remarkably well with his COVID and has recovered from that.
Today, after what he's been through, to be thriving 6 weeks after he was literally almost dead, it's nothing short of a miracle.
One of the most important contributors to my success, I think my wife. Her support and effort in getting me through this was absolutely incredible. Aww. She was there at every turn. My hopes for the future are to, resume normalcy, what I felt was normalcy. And normalcy was going back to my trainer, going back to the spa and doing my elliptical, and getting back into an exercise routine, which always made me feel good. It's a life changer. It gave me the ability to breathe. I always stuck with Dr. Rizik because I was always told he was the best, and he proved it. He's the best. And I'll forever be indebted to him for what he did for me.
Dr. Rizik, what an amazing story.
Wasn't that something?
Wow. And it's all because of this device right here that we're looking at. And this is, what type of device is this?
This is the Abbott Vascular MitraClip. And it looks very complicated, and it is. It's beautifully engineered. And I will tell you, the first time I looked at this a dozen years ago, I was a little intimidated. But with training and practice and spending a lot of time on it, you really do get used to it. And there's a lot of advanced knobology, what we call.
All right, before you do that, I want people to understand, and as you were telling me before we came back, is that in here is actually the device that's going into the heart, right?
That's right. This symbolizes the device going into the heart, and those two plastic pieces that you see signify the mitral valve. That's shows how we're going to grasp the mitral valve.
Okay, you got to show me what is going on here. How are you going to get this in there?
All right, so these knobs here can move us side to side. Okay, we can move it up and down, and that really shows what is like the leaflets in the heart, and then we can advance it. Hope I'm coming in nice and straight. Now this shows us going through the valve leaflets. Okay, that looks pretty straight. Now we can open up the clip arms.
Wow.
All right.
Okay.
And then when we're ready, we'll come back, and we're doing multiple little movements at one time. And then when we're done, we can close the clip arms around the valve, and that will bind those leaflets back together.
Wow. And we got to mention again that you're not just doing this by yourself. You have a team watching you, because I'm watching on the screen going, how is he doing that? And we're going to be in someone's body doing that.
That's right. Now, the next step is, in medicine, we say, see one, do one, teach one. So you've seen one, now you get to do one.
So, well, in the operating room?
No, right here.
Oh, here. Oh, okay. All right, good. Whoa, don't scare me like that. This is okay. So what am I going to do?
Okay, so come on over here. Switch places with me.
All right, I'm switching with you.
Okay.
All right.
Now, you're going to start coming back with this whole arm here. Slowly.
This whole arm?
Yeah, slowly pull the arm back.
Like that?
Yep, perfect. Okay. Man, you're doing that better than I did.
Okay, am I there?
Okay, you're there. Now you're going to push this little knob down here.
Hold on to this and push the knob.
Yeah, push the knob down. Yep, go. Push it down. Go.
Oh, there.
Okay.
It's pushed down.
All right.
Did I do it?
No, we missed, but that's okay.
What do you mean?
Here.
Well,
Ooh.
What do we?
There. What we want to do is push the arm down.
Okay.
Oop. All right, we'll cut
I'm
this.
so happy that you're doing this and not me, and I think the patient is too.
Okay, now close the clip arms.
Okay, there we go. So now I can
close the clip arms.
Whoops.
Close them. Go ahead, turn the knob. Turn it.
There it is.
Turn it. Turn it. Look at that.
Look at.
Oh my God, I'm going to be out of business. Perfect.
Am I there?
You're there.
All
now we're going to lock this. So push this down.
Okay.
This knob down. There you go.
I can't.
Here.
Oh, see, you didn't know there was a little lock there.
Yeah. Okay. Now lock it tight.
And then just tighten it up.
Clock it.
What do you mean clock
That
it?
way.
This
Away
way.
from you.
Like that.
Look at that.
All right, and it's locked off.
That's it.
That's it.
You did
I'm
your
all done.
first MitraClip.
That was nerve-wracking.
No, it was great.
It was amazing.
So now you've seen one, you've done one, and you now are going to go in and teach one now.
All right, but before we do that, there's another story that you want us to see, don't you?
He came to Dr. Riley and I, and we put our heads together, and we thought, he's probably too sick for an open heart surgery. Maybe a catheter-based repair, a MitraClip would be the best treatment or option.
So, all right, take a look at this. But remember, we're going to be going live in just a few to do a procedure.
Hi, my name is Simon. I grew up, had a love for horses. That's all I could ever think about growing up was horses. It's the love of my life. All of our children were able to go on into rodeoing. I was so fortunate that my children all did what we love, my wife and I. It's been a fun time with us as a family. Last winter, I noticed I lost a lot of energy, so I had to rest a lot. One day I went out to feed my horses. By the time I got to the 5th horse, I could barely pick up the flake of hay to feed him. My wife asked me, "How do you feel?" And I said, "Well, I'm hurting." And at that time, I was just hurting between my shoulders. And so she said, "I think you're having a heart attack." So the doctor gave me a 4-way bypass.
No, we thought it was completely fixed from the first heart attack and everything was going to be good. And
we were still talking about the first heart attack.
The day after Christmas, my wife and I were going to go roping, and I saddled up her horse, then I saddled up my horse, and that's when I had to sit down, and my wife asked me where I was hurting, and then when I told her, she called 911, and then I got in the ambulance. That's the last I remember.
He presented with a heart attack, but the main complication he experienced of that heart attack was a papillary muscle rupture.
The papillary muscle is one of the key components of the mitral valve apparatus. The mitral valve is a complex structure which includes not only the leaflets, but it also has anchors to the heart muscle itself. And the papillary muscle is essentially one of these anchors. If that anchor ruptures, then the mitral valve, you have a significant leakage of blood flow. The patient can become critically ill quite fast.
After evaluating Simon and discussing things with his family, we were not very optimistic that we had a solution for him. We felt that heart surgery would be too much for him to handle and that he would not recover.
Dr. Riley told me that Simon wasn't going to make it. And we couldn't believe that we were hearing what we were hearing.
The only thing that was keeping him alive at this point in time was the Impella.
An Impella is an artificial pump, which literally takes over the pumping function of the heart to all the vital organs of the body.
I am a nurse and I knew what those monitors were telling me, but I kept looking at him and I'm like, when is this going to happen? I don't see anything changing. He's fine. He's fine.
The next morning he was still with us and Dr. Riley came in and said, "I have some awesome doctors that want to perform a procedure."
I spoke with Dr. Rizik about 5 o'clock in the morning and asked him, "How do you feel about doing something crazy?" His response was,
"It might be crazy," and I said, "As long as it's not stupid."
He said, "I'm in."
There are certain situations where it seems like the patient's condition is so dire that we're not going to be able to fulfill our mission of helping people. But fortunately in cardiology over the last few years, we've made significant advancements in our ability to treat really sick patients. And in this particular situation, this is one of those moments where technology, the expertise we have amongst our physicians and staff really allowed us to make a Hail Mary attempt at treating somebody and really improving their life and allowing them to spend more time with their family.
When Dr. Riley came to us, he mentioned the possibility, could we consider doing a mitral clip to try and save this patient's life? The clip is generally used in very elective, very stable patients. But in this particular case, we were being asked to consider putting a clip in a very, very critically ill patient. This has not been done very often in this country.
So the goal of putting a mitral clip into his valve was to support the valve and bring it back together and prevent all of the leakage that we saw on echo. We were initially just trying to use this as a temporizing maneuver just to buy time to potentially do a definitive surgical repair for the valve. Once Dr. Rizik had the clip on the valve, we turned color on. That allows us to show the flow or the regurgitation. And it was like somebody flipped a switch. It just wasn't there anymore. It was an extraordinary moment.
We were all sitting in the waiting room, and when those doctors walked out, we were all just waiting. Is it yes or no? Was it successful or not? Is he still alive? And he said,
didn't tell us if it went well or not. He didn't tell us at first. He just went into explaining the procedure they did. And so we're all like,
is he alive?
Is he okay? Is he not okay?
And so it was a miracle. We still can't believe that Simon's still here with us today. I'll never be able to thank him enough.
In 33 years of doing catheter-based procedures, this is definitely one of the most satisfying undertakings that I've been a part of. Not just stabilizing the patient or making him better, but returning him to his family.
I just feel that the Lord sent us that day to that roping where I was taken was one of the only ones that would probably have worked for my situation. And so I didn't get to go to heaven. I got to stay here. There must be a reason.
We got everything that we asked for. We got him out of heart failure, we got him out of the intensive care unit, and he recovered remarkably well so that 6 weeks later, he was in good enough condition to tolerate heart surgery. With his new valve, we expect that Simon will have many more years of health and stability so that he can get back on his horses and enjoy his roping.
Wow, what an amazing story there. We are now here in the operating room, and Dr. Rizik, I'm in your office, but we saw everyone out there. Let's introduce where everyone is now here in the operating room.
Okay, so we've got this is really a team effort. So we got a really great team here. We have Garrett, he's our x-ray tech. We have 2 nurses in the room. We have Sophia and Brittany. I don't want to miss anyone. We have Colin, our clinical support from Abbott. Abbott's done a spectacular job educating and supporting these cases. We have Dr. Schwartzstein. He is our anesthesiologist. We have Dr. Burke, whom you've met. He is our echocardiographer and imager extraordinaire. He is giving us some of these spectacular images. And I'm also pleased to welcome back Dr. Alok Sharma, who's joining us from Minneapolis for this week.
Yeah, and next to us?
Dr. Malik Shah, interventional cardiologist, and you know this guy.
Yeah,
always exciting to be with you guys.
Thank you. Let's talk about where we're at in this operating room. Where is this located here in the hospital?
This is our cardiac catheterization laboratory. This is our Siemens lab. Siemens has supported us in all of our research and innovation endeavors, and you're going to see the Siemens lab gives us some spectacular images. You're really going to love this. If you look at the screens, you can see on the what the audience sees on the left of their screen. They're going to see the X-ray images. We synthesize multiple images to help us to do this. So on the left is the X-ray picture. To the right, Dr. Burke is giving us echocardiographic images. So it's multimodality imaging, multiple imaging modalities to help us to drive this device.
Wow. And you, the audience there, are watching this live right here, right now, which couldn't be done, we say, what, 5-10 years ago?
Just 5 years ago, this particular 89-year-old gentleman with very severe coronary disease and damage to the heart muscle, and because of that, a leaking mitral valve. 5 years ago, this probably would have been hospice or no treatment options. He's not a good candidate for surgery. We talked about how we sit down, Malik and I sit down with the surgeons, and we make a decision, should this patient be catheter-based or surgical? He is not a surgical patient, so 5 years ago, he would have had no option. Today, because of this beautiful device, this MitraClip, we actually have a therapy that we can provide this patient. And if you look at this, you had a chance to use this. Now, we have this all the way up to the heart, inside the heart, but you'll notice this catheter is going through the vein in the leg. It is not going through the chest wall. We didn't have to open the chest, but rather we access the heart simply by going up this tiny opening in a leg vein.
So, all right, we're in here live now, and I know we were showing some of the demonstration earlier, but now that we're in the operating room, let's go ahead and look at what's going on here. As we were talking, the blood is flowing back, which is not the best here to be happening.
Dr. Burke, could you kind of take us through what you're looking at, the images you're seeing, and what's important for the audience to look at?
So what we're looking at right now is from inside the heart, we're looking toward the mitral valve. So we're coming from basically the lungs toward the mitral valve, and we can see that we actually have our clip up right now.
The clip arms are open.
Yep, and you can see the color. All of that red coming at you is blood going in the wrong direction. So that's not what's supposed to happen. It makes the heart much less efficient, and it also pushes blood back into the lungs. So with this, we had taken a picture earlier of the pulmonary veins. Now this is actually looking at blood normally flowing into the heart. Anything above would be going toward the heart, and that's normal, like this. This stuff going backward is not normal. So that's actually blood pushing back into the lungs with every heartbeat. Unfortunately, the lungs get caught between the right-sided pumping chamber and the left-sided pumping chamber, with both sides trying to fill it with blood. That's not efficient, and that causes the lungs to fill up with water and makes people feel short of breath.
So Dr. Burke, show him the line. Show him that line that you're looking at.
So there's this line here.
So everything below it is backwards flow into the lung.
Everything below is going the wrong direction and is going back into the lung, congesting the lungs.
Dr. Shaw, what does that do to patients when you see them in the office?
So when they come into the office and the blood's not moving forward, that means nutrients can't get to the place that need to go in the body. Plus, when the blood's going backwards and it's soaking the lungs get drowned and you can get short of breath, you can feel miserable, you can't walk very well, and sometimes people can even die from it. So it's a big deal.
So, Dr. Burke, what you're going to show us as we proceed forward is we want to see that backwards flow. You're going to give us multiple images of that, and we want to see if we can alleviate or eliminate that backwards flow into the lung once we close the clip.
Okay. As we're seeing it going on, let me ask you this, doctors. What causes this? Why does it weaken like that?
Well, in this particular case, I've been following this gentleman for almost 30 years. He had his first heart attack, then he had bypass surgery, he had some stents, and over time the heart muscle has weakened. And as the heart muscle weakens, it enlarges, and as it enlarges, it pulls the mitral valve leaflets apart. So instead of those leaflets coming together, as the heart enlarges, there's a gap. So what do we look at on when you are evaluating these patients, Dr. Shaw?
Sure. So there's two types of people that come to see us with this sort of issue. One is somebody who has a lot of symptoms, meaning they're short of breath, they're having fatigue when they're walking, they're having swelling in their feet. And then there's another type of patient that comes in and their doctor hears what's called a heart murmur, where you can hear the blood flow abnormally across a valve. And when we see something like that, that's when it sparks our interest and says, hey, there could be something here. There could be a leakage in one of the valves, particularly this valve, the mitral valve. And then we start to do a workup, which can include an echocardiogram, which is like an ultrasound that's painless that can actually look at this valve.
Which is what Dr. Burke is showing us right
absolutely.
now.
And Dr. Burke's showing it to us in both two-dimensional and three-dimensional imaging, which really gives us a great sense of exactly where the issue stands.
Let's explain to our audience that's watching this live right now, as we're here and we've started the operation here, and people have to understand that it takes a little time. You guys kind of like start and you stop for a minute to watch and see what goes on before you proceed. So we're not just pausing here for just us to talk. We're actually in the surgery.
Dr. Burke is doing measurements. I have to pause to let him do the essential measurements that we can look at pre-clip and post-mitral clip so that we know it's successful. And the thing is, we might grasp those leaflets, not like it, but we have do-overs. You get a mulligan on this. You get to open the clip arms again and try and optimize the position. So we're going to get moving here. We're going to get rolling here on the clip procedure. So you can see the clip arms open. And I'm going to close the clip arms, and you'll see them closing a little bit on the echo image to the right. And now I'm going to cross the mitral valve, and I'm just going to dip just slightly below it. Dr. Burke, how do you like my position?
Great. So what we've done is we followed you in real time on 3D imaging with the Siemens ultrasound machine here. And we can actually watch everything going on live without having to make a lot of adjustments.
Okay, so show me the 3D again here. Let's just see what we got.
Okay, so we can come back here. And I'll show you where we are looking from the left atrium. And again, that's the chamber where all the blood comes back from the lungs to get back to the heart. And we'll look at this as if we're standing inside the left atrium.
Wow. That's amazing. And doctor, as I keep saying this, Dr. Rizik, this is like a ballet in here, watching you move the clip and how you all are working together is so amazing.
Well, it's a real team effort, and everyone in the room has a role. Everyone in the room is doing something. Now, Dr. Burke, what do you think of my position right now?
So far, this is looking great. So we went into the left ventricle, the main pumping chamber of the heart. May have rotated the clip just a tiny bit when we went in, and that sometimes happens with just torque.
So tell me which way you want me to go now.
So this is looking like a little bit of a counterclockwise rotation would be ideal. What I'm focusing on is making sure that those arms show up again in the same plane as the mitral valve leaflets.
And what's really cool about this, Brad, is that Dr. Rizik and Dr. Burke are in such sync that this makes it such that we don't have to do open heart surgery, that we can actually do all this through a small incision, because Dr. Burke is guiding them so precisely as to where that clip should go.
Yeah, and that's why this procedure is so important now for a lot of people to have this instead of having to open the heart that we've been told before.
Yeah, absolutely. It's fascinating. Not only can this elongate somebody's life, make them live longer, but it can give them a higher quality of life so that they can walk farther, so they can enjoy the activities that they want to do day in and day out.
Yeah.
So that's superb. I mean, 20, 30 years ago, as Dr. Rizik highlighted, a patient like this may not have any options, and now they have several options. And the other thing is that this technology has been proven to be durable, meaning that people are living long with these valve technologies, and it's lasting. The impact is lasting.
I didn't mean to cut you off.
No, go ahead, David.
So, Dr. Burke, do you want me to roll more posterior, or do you like where I am?
Actually, we're looking very good right now.
And tell them what you can see in terms of the clip arms, or the leaflets tapping on those clip arms.
So right now, what we're looking at, let me just come back here. We're looking at the mitral valve here. This is the anterior arm, this is the posterior arm, this is the posterior leaflet of the mitral valve. That's the anterior, and they're tapping now on those arms. Now,
so I think I'm going to drop my grippers here pretty quickly. What do you think?
I think that makes a lot of sense.
So I'm going to drop the grippers, this knob here, and what that will do, that has those little hooks on it, and that'll capture the valve, okay? And now I'm going to close my clip a little bit.
Give back.
Giving a little back so that we don't have tension on the valve. I think I got that thing grasped, Dr. Burke. What do you think?
Yep, looking pretty good here.
That looks pretty good. Bob, we don't want any tension on this valve. Do you want me to give back more, or?
You're going to have to give back a little bit more there.
And I left a little bit on that medial side that I didn't want to. And I'm pretty tight now.
Yeah, so we still have a little leak there just to the side. To the left side, you can see that jet is still there. We want to try to get rid of that. That's going to be our primary focus of treatment right now.
So what do you think we try this again?
Yep.
And what I'll do is I'll move the clip a little bit to the medial side, as we call it, or the left side of the screen. Dr. Burke, will you give me 3D again? Let's look at my arms on 3D, and let's make sure that we're where we want to be. So this is the beauty of this technology, is we made a grasp. The grasp was pretty straightforward, but if we don't like the amount of leakage that we've left, we can just undo it and take another shot at it.
And I was watching the 3D and watching the blood flow, and then I saw that when you guys started to close it, the blood did kind of slow down a little bit going back in.
No question about it. No question about it.
What was happening.
Okay, so now what I have to do is turn my clip a little bit counterclockwise. If you look on your echo screen, on the right-hand portion of our screen, there we go, that's better. Bob, what do you think of that in terms of my...
so this is what we're looking at on the screen, and that's what we're trying to show everybody. So now we're looking much better. We have been rotated a little bit to the right, which was clockwise, and we're trying to get just a little bit more counterclockwise to optimize this and make sure that we see everything as best we possibly can.
Now, I think I need to go more medial. Clearly, I need to go more medial. Would you agree?
Yep. So we're here now.
So medial on that color picture to the right is going to be to the right of your screen.
So
how would you...
Go ahead, doctor. I know you're talking
here.
Yeah.
I mean, so I'd just add that the great thing about this, as Dr. Rizik highlighted, is that you can make many adjustments to make sure that you're getting it just right, just the way you want to. And this patient started with what's called severe leakage. So anything that we can do to reduce that leakage is going to be helpful. But we want to make it as effective as possible by reducing it as much as possible.
Okay. So, Bob, go to X-plane again for me.
Yep. And here in our biplane image, we're going to see the clip here.
Yeah, I think I'll go a little anterior there.
And the thing they're doing is that they're putting the clip on right where it can go to be effective at reducing the leakage and making sure that it doesn't get in the way of anything else that's in the heart.
Wow.
So this is looking good. I don't see much medial right now.
So you think this is a good place to make another attempt? So, Bob, just go to 3D one more time. Should I open the clip arms a little bit more, maybe? Okay, there we go.
Go.
And how does it stay there with you turning it different times? I mean, clipping on, that is what is the main thing? You're trying to find the right place to clip
Trying
it?
to find the perfect spot, yes. So just orient me. I want to make sure I'm 12 o'clock, 6 o'clock, and that I'm in the right medial. Now you can see I'm more to the right on your echo screen, so that's more medial. And I'm just going to go a little counterclockwise here, Bob, to try and get that more 12 o'clock, 6 o'clock. There we go. That's better. You can go X-plane now. And now I'm just going to move it back on the screen a little bit. There we go. Should we? My posterior leaflet's being a little fussy. I don't think my anterior's in, Bob.
Nope. It's sort of...
So Dr. Rizik's using the word anterior and posterior. So the mitral valve has, as you probably have heard, has two different sort of leaflets or doors that open and close and allow blood to go from one side to the other. And so one is typically referred to as the anterior leaflet and the other is referred to as a posterior leaflet. So he's making sure that he's got the clip right where he wants it to on both of those doors.
Yeah, let's talk about how important this clip is, because as we're seeing him being able to be able to move it and maneuver it to the right spots. That's why this type of operation is so important compared to opening the chest and having
That's looking better.
Absolutely. Open heart surgery has a long
nicely
length
right
of
now.
recovery time, meaning because you're under general anesthesia for a long time. You have to make a big incision. This one, as Dr. Rizik highlighted, was a small incision with the faster recovery time.
Check the arms one more time, Bob.
Patients
Go
are
to
walking
3D.
around in the
Let's just
afternoon
make sure
and
we
go
like
home
the
even the
arms.
next day sometimes. So
You can see, you guys, that the leaflets are tapping on the clip arms. We just want to make sure we get the right position toward the front and back and from the side to side views so that we get the optimal grasp on this. It's, these
Still
this
a
is
little
like
bit more countered than perhaps perfect.
Okay.
It's tricky, and one of the main things that we're really proud of is Dr. Rizik has a world-class experience in doing this, and so with experience, he knows exactly how it
go
should
back to
feel
X-plane,
and
Bob.
where it's best to place the clip.
So if you're just tuning in right now, you are watching a live heart procedure right here on AZTV7 with Dr. Rizik and his team.
So this looks better with that rotation.
Do I have enough posterior in there, Bob?
Posterior is laying right on top there. Anterior is laying on top.
Let's try it one more time, shall we? Grippers are down. That's
Definitely
those little
anterior.
hooks.
Posterior looks like you're nice and tight.
Lost the posterior.
Oh.
Okay. That's what we happened on that one is we had them and then we lost it. But this is, you get the gist of what we're trying to do. All right, so.
Dr. Shaw, as he's working that, let's remind people what this surgery that is going on right now in the heart, and that is putting a clip on
the mitral valve. So the heart has 4 different valves in it that open and close and allow blood to go from one side to the other. And one of the most important valves is this mitral valve that allows blood to go from the left side of the heart from one side to another.
Yep.
And sometimes with time and age, it can start to leak. So what Dr. Rizik is doing is that without open heart surgery with a small incision, he's going to actually clip the 2 leaking doors of that mitral valve together
That
to allow
rotated
for
a
less
lot on you.
leakage.
May need to
It's fascinating. And 20, 30 years ago, this would never have even been thought of. And now to think that it's come this far.
So
it's really a testament to
Let's see it,
science,
Bob.
innovation, and the human spirit.
Yeah. Okay, so as they're working there, I was wondering, okay, it's going to be clipped and closed off. Is that still working for?
Yeah, absolutely. So in open heart surgery, they've noticed that sometimes they put in just one stitch and sort of
All right, Bob,
put together
so let's see it.
that leaky valve leaflet. The valve still
Clean
functions
that,
well, and
Bob.
we reduce the leakage. And so this mimics that without doing open heart surgery. And so the valve can still function, and the leakage is much less.
Wow, amazing.
And I think the most exciting thing is that there have been countless trials now that have shown that people who have this procedure when they need it have reduced incidence of needing to go to the hospital, reduced need for taking medications, walk longer, and live happier. So that's what's so exciting and so satiating from a physician standpoint to be
That's what I
involved in
wanted to do
procedures
right
like
there,
this.
Bob.
Amazing.
Yep.
And let's remind people you're seeing a 3D image, and also you're seeing an X-ray image of what's happening on your screen.
Yeah, absolutely. So on your screen right now, the right side is a two-dimensional image that shows exactly where Dr. Rizik is placing the clip that Dr. Burke is providing. And on the left lower side, you have X-rays that sort of give us another perspective as to where the clip should be. And then occasionally, Dr. Burke, when needed, is giving a three-dimensional image. So with all of those imaging technologies and modalities, Dr. Rizik is able to place the clip exactly where it needs to go. And just like any quarterback, Dr. Rizik's also looking at the blood pressure, the heart rate, and everything else, and just syncing all that together.
It's amazing.
So during the procedure, we also make sure that we're giving blood thinners to make sure that no blood clots form on the equipment, and we've got a team like Dr. Schwartzstein and others that are watching that the whole time.
Yeah, and Dr. Rizik is working with his team so amazingly here. So, Dr. Shaw, I know you're talking to me a little bit here,
Yeah.
but let me ask you, I'm hearing a question come in from Brian from Mesa. He was wondering, when should someone have a procedure like this?
Yeah, absolutely. So you want to do it mainly when you're having severe leakage of the valve and symptoms. We want to do things when people are not feeling well, but we don't want to wait too long either, because sometimes the damage can become irreversible if we wait too long. So there's a sweet spot where you're starting to have some symptoms and you have the valve issue, and that's where you really want to address it sooner rather than later.
Posterior leaflet.
Great question.
Better.
Okay. All right, let's see it. There we go.
So
looking
there's
better.
our posterior leaflet. That
looks great, David.
I'm just focusing while you're talking. I love having you here, Mullet. You guys are great.
And you know, it's very common here, which is very nice, and that's what's so important about this operating room as we're sitting here talking as the doctors performing. But Ellen from Scottsdale was wondering, how long do you train to do a procedure like this?
Sure. So first there's a training to become an interventional cardiologist, which means that you went to medical school, you did residency, you did a specialized training and fellowship, and then specialized additional 1 or 2 years just to become an interventional cardiologist that can put in stents and valves and do these sorts of procedures. And then the training for this particular procedure is even more vigorous, with the company and Dr. Rizik and several scientific leaders getting together and learning from each other.
Go explain.
And so he's
3D.
had some of the most experience in North America in doing this procedure, but it takes a long time to master this procedure.
And some of these cases, you know, we have a half hour to do this case. Some of these cases take more than a half hour. You know, we're trying to, some of these procedures can take 2 and 3 hours. We're trying to obviously condense it into, you know, a 1 hour segment.
So what is also amazing, Dr. Rizik, is that this is a life-saving procedure, and I think that's what people have to realize. Like before, as we were saying, if you're just tuning in, 5-10 years ago, this would not be possible.
Bob, you want to clean that 3D up so I can...
Yeah, it's a great question. So the first thing is that we studied this in patients that didn't have any surgical option, and we found out that, hey, this actually saves lives and helps them live longer.
Okay, good.
Now we've even compared it to surgery in certain situations and find that in some levels,
happy with this?
it might be better than surgery
better
for some patients.
Doctor, you were calling out to the other doctor, Dr. Rizik. There's so many doctors in here. Dr. Rizik, you were calling out to Dr. Burke. What was going on here?
Okay, so what we're doing, sometimes the heart can push our clip around a little bit. So we're just trying to perfect our movement, because every movement, we move one way and the heart sort of pushes us a different way. And so you just calmly, slowly, you know, keep adjusting and fine-tuning your movements. Bob, I think we're looking pretty decent there. Colin, what do you think? All right, Bob, I'm going to try a grasp here. And I'm going to try closing and seeing, giving a little bit back.
One of the coolest things, as you can tell, is he's doing this while the heart is still beating and while the heart is still doing its other functions. So to do that, he's got to take into account that motion at the same time.
So now we've grasped, and I'm tightening down, and we've got a pretty good grasp there. That, in fact, that looks pretty good. We still have some jets on either side. Bob, you want to just show the one view of the LVOT view?
Sure, that's easy.
So now you can see a lot of that color is reduced. This is great. A lot of that color has reduced. It's not as severe as it was before. So what we have to decide is, do we like where this is now? Do we, have we reduced the amount of leakage? And one of the ways we're going to make that determination is, Dr. Burke, you want to show your pulmonary venous flow and see what we've done to that?
Do that.
So as he's doing that, Dr. Rizik, I have Holly from Tucson's asking, how long can this clip stay there? How long does it stay?
This clip's going to stay the rest of this patient's life. This patient is going to have this clip for the rest of their life, and in over 90% of the cases that we perform this, the clip will be, this patient won't need another therapy because of the clip.
Well, okay, Robert from Phoenix was wondering, as we're getting more images, is what's the recovery time after this surgery?
99% of our patients go home the next day. And I want you to think about that in contradistinction to surgery, which is still a great therapy. Surgery is a great therapy. 99% of these patients will be up and walking later today and home tomorrow.
Wow. And again, if you're just tuning in right now, you're watching a live procedure here at HonorHealth at Shea with Dr. Rizik and his wonderful team.
So Dr. Burke, if I may, Dr. Burke, tell us what you've got here now and compare this to what we had before.
So again, what we had seen before is everything above this line, this baseline, is normal flow into the heart from the lungs. So this is normal and this is normal. Beforehand, we actually had reversal of flow with blood going backward to the lungs after every heartbeat. This little line here is when the heart is beating. So when the heart was beating, we had a reversal and blood getting pushed back into the lungs there. So this is a normal pattern and definitely is a marked improvement from what we had to begin with.
That's huge.
What does that mean to you when you see these patients in the office?
Yeah, so one of the biggest problems when my patients have a leakage of the valve is that blood is going backwards into the lungs. That blood that you see below that line that Dr. Burke is highlighting. And once we get rid of that blood that's below the line or going back into the lungs, they feel outstanding. They can walk longer. They're not getting short of breath. They're not getting swelling in their feet. And they love it. So that is the biggest thing that we look at, and it's awesome that's happening right now.
Requirements? What about oxygen requirements?
Great point. So some of these patients are on oxygen all the time, home oxygen, where they have to lug around a tank just to keep their breathing and oxygen saturations at an appropriate level. A lot of these patients, once you take away that leakage and the blood's not soaking the lungs, no longer need oxygen. And you can imagine they feel a lot better without that oxygen.
I know we were seeing the stories beforehand about how this surgery has changed a lot of lives, as it's so important to do. And again, if you're out there at home right now, you must see your doctor if you're having breathing troubles, if you're feeling the heart, and you're a little scared, but this is not.
Absolutely.
I'm it's amazing.
Yeah, I mean, heart disease remains the #1 killer of both men and women in the United States. 1 in 4 of us likely will suffer from heart disease from some extent. And so it's really important that you always are proactive about your health. Make sure your family's proactive about your health, because there's so many things that are out there with modifications and medications or even technologies like MitraClip that can save lives, especially if you can get there sooner rather than later.
We're off, right?
So as we are here in the operating room with Dr. Rizik and his team at HonorHealth, so let's talk about this room again. If you're just tuning in, this is an amazing operating room here.
Yeah, so in order for a patient to avoid open heart surgery, you need to make sure you have the best technology and imaging around, and this room provides us with that. So you've got huge screens that allow the physicians to actually look exactly at what they're doing in, day out. You've got 2-dimensional imaging, you've got 3-dimensional imaging, and then you mix that together with x-rays, and with that you're getting a really comprehensive perspective of the heart without without doing open heart surgery. So it's huge. And then you also have to have a great team around you, technicians, staff, anesthesiologists, and imagers that actually allow us to work on the patient without having to worry about every detail. So it's fantastic.
It's just amazing in here to be with Dr. Rizik and his team. And as I always say, it's like a ballet in here. And it's nice, relaxing, and calm. And that's what's so important about this surgery.
So what we've shown throughout the course of the last 30 minutes is really our ability to use this clip to grasp the leaflets. We've used the clip to reduce the backwards flow into the lungs. And what I love about this, what I especially love, we were able to demonstrate that for our audience, but we're also able to demonstrate you get a do-over. If you don't get exactly the grasp you want, you can release it, which is what I've done now, and we're going to make another grasp. The beauty of this procedure is in the fact that you can make multiple attempts. Sometimes with some medical devices, once it's in, it's in. This device allows you to take multiple attempts to optimize and perfect the result. And that's what our motto is. We want technical perfection. So we're going to take a couple of more grasps here until we get just the perfect grasp. But I think we've shown that you can grasp this, reduce the amount of leakage that goes back into the lungs, and make these patients feel better. And you saw some of those testimonials. Some of those patients you saw in the testimonial, took 3 or 4 grasps to do it.
Yeah, and as we know that the surgery could be different lengths and stuff, and as they're working with this amazing mitral clip, which is so incredible to do. Doctor, as you're working there, you wanted to bring up a very special person here at the hospital who meant a lot to you, and let's talk a little about how that person has passed due to heart problems.
Well, Dr. Burke is taking measurements. I'll make a pause. I told you one day on the show that behind the scenes, you see the doctors and the nurses and the technicians here in the room, but behind the scenes is a whole group of men and women who keep the cogs, keep the wheels in the cath lab moving. They are just wonderful, wonderful people, and they're unsung heroes, and you never really know their names. Well, I want you to know the name of one. Daryl Moore was part of our HonorHealth family, and he kept everything in this cath lab working beautifully. If something wasn't working right, he came up to fix it. And Daryl died suddenly and tragically recently of cardiovascular disease. And Dr. Shaw and I and Dr. Burke and Dr. Riley have decided that we want to dedicate ourselves and all of our efforts to Daryl and his family. You see Daryl here, his wife and his son. And our efforts are being dedicated to Daryl and his family in the hope that someday soon we can eliminate cardiovascular disease as the #1 killer of young adults in this country, and in the hopes that families like Daryl's will not be torn apart by the consequences of coronary disease.
So it is, and it's very important. Doctors, thank you for letting me come in. You, the audience there, have seen a live heart procedure right here on AZTV7. If you want more information, you can go to aztv.com/procedure to see more of Dr. Rizik and his team's work. So, Doctor, thank you for having us.
Thanks for joining us, Brad. Thanks for spotlighting heart disease.
Thank you.